My name is Sarah Yardley. I'm a clinical academic conducting close-to-practice research that is seeking to account for real-world dynamics in authentic contexts as people do the day-to-day work of healthcare, creating meaning and making sense of their experience. My current study explores how human factors might be harnessed in improvements to cross gaps and boundaries, producing relationship-centred care. In this talk, I will highlight how my study design is being strengthened by integrating a research engagement group made up of people with lived experience of palliative care and psychiatry. We hope this will ultimately help address the problem of how different groups, such as patients, carers, frontline professionals, researchers or policymakers, find each other hard to reach. So what's the big idea? We need to see relationships as the improvement intervention. In complex systems such as healthcare, people develop workarounds and take risks in their day-to-day work, by which I mean all efforts and activities, because they are looking for ways to address gaps between what ought to happen and how things work around here, that is in practice. Their actions and inactions will have knock-on effects for themselves and others, some of which are unintended and/or unpredictable. So why does this matter in palliative care and psychiatry? Both are healthcare fields where multiple people form transient teams that are not easily relationally connected, but meaningful connections are necessary, in fact critical, for holistic, safe, high quality, patient and carer-centred practice. In both fields, therapeutic and professional collegiate relationships often are the intervention, and the outcomes are a result of relational glue, the in-betweens holding together, not of task-based or instrumental transactions. And so it is important to think about these in-betweens, the relational glue, and how these might provide close-to-practice improvement solutions. I've invited Lynn from the engagement group to share some of her thoughts on this.
I think this work is very important because not everyone gets the same care or can speak up for themselves or for those they love. And I want my experience of caring to be used to make things easier and better for others. When I had cancer, I was lucky to be treated in a hospital that offered excellent support as well as good treatment. And support is so important to us, no matter how old we are. My cancer consultant talked to me, explaining everything. Looking at my husband and his dementia and the COVID crisis, it has had a real impact on him, both physically and cognitively. He's in a care home, he knows all about COVID, but cannot understand why I'm unable to visit him. I'm in one box and COVID is in another. It's awful how human connections have gone. While I was caring for a friend at the end of his life, I understood how difficult it was for professionals to get things right for him. It was important having support from someone who knows you, knows what you're going through, a person who you can talk to and rely upon, and people who go beyond supporting carers as well as patients really do make a difference.
Together with the engagement group, I have expanded on the theory of work as imagined versus work as done. Work as imagined is what happens on paper, the road designer's vision of this famous Swindon roundabout, if you like, to which we have added work as declared to mean what is included in official representations of effort. For example, how we, as good drivers, use the roundabout, preferably on an idealised sunny day. In contrast, work as done is what actually happens in practice. We have expanded this by adding what we are calling work as matters. What matters is the driver's work in successfully navigating the roundabout on a busy, stormy day when late for an important event. In healthcare, work as matters is the efforts needed to achieve priorities, what is actually most important to those at the sharp end of healthcare activities. We will use these ideas to explore how to harness the best of human workarounds in healthcare improvement initiatives while still mitigating risks. We have also jointly designed the methods for data collection and analysis to focus on safety as a value-based concept, exploring nuanced approaches to evolving and emergent priorities of living with risk and uncertainties, and active care ingredients such as what is the make or break factor in relationships? When is not following the rules the right thing to do? Who does the work of integrating different sorts of expertise? And what does success look like in the absence of cure? I am hoping the work of the study will model relational learning as we practice what we preach, seeing relationships in all their complexity as the intervention. Thank you very much for listening. Please get in touch if you want to explore these ideas further together.